Thank you for the invitation to speak. I have two disclosures. One, I'm an adult hematologist. I was trained as an adult hematologist for the last 30 years. I behaved as an adult hematologist. The second is I treat both acute leukemia and I also do transplantation. So it really offers your understanding of why I'm so confused. Okay, so after you achieve complete remission, what do? Should blood and marrow transplantation be considered a legitimate option to chemotherapy? So a number of things are good about allogeneic stem cell transplantation. The good is that while only about 40% of individuals have HLA-matched sibling donors, unrelated donor searches are now much more fruitful. And not only that, because of DNA-based sequencing of the HLA loci, this makes unrelated donors nearly equivalent to siblings in terms of outcomes. And of course, further good news, there's alternative donors in play, umbilical cord blood transplant and haploidentical family members. And naturally, the reason we may choose to do an allogeneic stem cell transplant in an ALL patient is to take advantage of immunity, that is to say the graft versus malignancy effect. It's definitely operative in ALL, perhaps not as strong as in myeloid disease, but it's definitely there. Then there's the flip side. What about the bad issues of allogeneic transplant? Well, there remains a high treatment-related mortality, largely due to infection and graft versus host disease. And something people don't talk about much, you could be cured, but have a significantly compromised quality of life due to chronic graft versus host disease. So we replace one deadly illness with one that gives protracted poor quality of life and prolonged medical care. So that always has to be part of the decision-making when one considers allogeneic transplant for ALL. I think my charge is to address the question, should allogeneic stem cell transplant be considered the better treatment choice for consolidation in the adult population? There isn't a whole lot of data AYA specific, but I'll do my best with this question. Tomorrow I'm going to talk about chemotherapy, and I'll get a chance to argue with myself. Now, if you look at the NCCN recommendations for the AYA age group, 15 to 39, these 6 regimens pop up, and they're not meant to be the only choices one would have, but they're all pediatric inspired. And the implication is that for adults in this age group, one should be taking the approach of chemotherapy and using allogeneic stem cell transplant as an alternative. If they clinically fail, what are these regimens? That's the implicit sort of unwritten message in this. I do note there's 3 asterisks here, so at the time that this was published, 3 of the trials weren't completed yet. And so recommendation for a regimen of which the outcomes weren't known simply because at the time they were pediatric inspired and felt likely to proving fruitful. Well, I think there are a number of reasons as adults, leukemia doctors, we think about performing an allogeneic stem cell transplant in first remission. Generally unfavorable karyotype or genetic profile, the very high white count at presentation, one's failure to achieve a morphologic remission in 4 weeks. There's evolving data, and we just had a panel on this, where MRD positivity at 4 or 8 weeks of induction is even prognostically important in adults. And something that we think about at UCSF, the inability to tolerate more of the curative chemotherapy agents. So if you have a significant problem with asparaginase, let's say, and you can't get more, is that a reason to really change gear and to think about a transplant? And of course, there may be a clinical trial opportunity that involves transplant that might be the best choice for your particular patient. Dr. Logan already showed the CIBMTR curves. This is looking at age under 20 using a HLA-matched sibling donor. And at 6 years, the curve is flat at about 60%. So one may look at that and say, well, these are children. These are people in the pediatric age group, by and large. 60% is not a very good number, especially when you compare to outcomes with chemotherapy regimens done in the pediatric style. However, implicit in this is there's a reason these individuals went to transplant. It's not because they're standard risk. They had some very high risk feature that led their physician undoubtedly to recommend transplant over continued chemotherapy. So if you look at it from a transplanter, you might say that data looks pretty good. And Dr. Logan showed these as well. If you substitute a sibling with an unrelated donor, you drop a few notches at 6 years. If you then get into the true adult age over 20, we're down 15 percentage points and so forth. Okay. This probably was shown this morning. I wasn't here this morning, so I don't know exactly which was presented, but one of the largest trials ever done in adult ALL was the United Kingdom ALL 12 trial, ECOG 2993, and basically was an allocation study so that if you went into remission and you had a HLA-matched sibling, you were then assigned to go to culminate your treatment in a sibling allogeneic stem cell transplant. The conditioning regimen was quite good, total body radiation and etoposide. If you did not have a donor, then you were allocated to the right side to be randomized either to receive an autograft or consolidation followed by maintenance chemotherapy, and there's 3 rounds of high-dose methotrexate consolidation for everyone before their final assigned treatment. And it showed the classic allogeneic transplant curve comparing the two, donor versus no donor, in the Philadelphia negative population. Transplant is doing worse initially with more deaths, but the curves then meet and cross at 2 years. The first 2 years is because of treatment-related mortality, which begins to slow down, and then transplant remains apparently superior thereafter because of more relapses in the chemotherapy arm. So a demonstration, if you will, of the problems and the benefits of transplant. Problems being treatment-related mortality, the benefits being graft versus malignancy. And this was, despite the crossing of the curves, did generate a significant p-value. And it was true, and some people were surprised by this, whether you looked at a high-risk population or a standard-risk population. Because of the loss of power, the p-values disappear, but the curves look really quite the same as the initial overall patient population. So when people foresaw this information and thought about it, there was the propensity to think that instantly in the adult world, everybody would now, with ALL, go to a sibling allogeneic transplant if they had a donor. And that never happens, at least in the United States. Again, furthering the point about graft versus malignancy, you cut your relapse rates in half, whether you're standard risk or high risk, by having a donor present. And transplant, the bad news is there's about a tripling of treatment-related mortality compared to not having a donor and receiving chemotherapy. Okay, well, on the backside of this, then a meta-analysis was performed looking at 13 trials where the same basic design was in play, allocation based on the presence or absence of a sibling donor. There were, I think, a total of 18 trials that met criteria for the design, but only 13 were chosen because they could actually contact the principal investigator and get the primary patient data that was updated. So they're using raw patient data, not published data. And in these trials, the majority were men. About a quarter, roughly, it ranged from 22 to 60% of trials had individuals who were 15 to 24 years old. So the AYA group is represented in these adult trials. The median follow-up, the least was 4 years, and the best was 16 years, so good follow-up on this. Those lost to follow-up within 5 years of transplant was extremely low. And those who had a sibling donor in these trials ranged between 26 and 49%. And then those that reported no sibling donor ranged 41 to 51%, and of interest, 8 to 19% had no sibling, therefore could have no sibling donor. And so I've boiled down a lot of data into this table. It's a bit dense, sorry about that. But basically the hazard ratios speak for themselves. We've looked at 3 endpoints: relapse, treatment-related mortality, and overall mortality. And within each of those endpoints, there are 3 groups of individuals. Those who, without a donor, were allocated to receive chemotherapy. That's a distinct group from those who, without a donor, were allocated to undergo autologous transplant, versus those who are allocated to a randomization between chemotherapy and autologous. And then everyone, those 3 groups are lumped together in the blue. And basically, if you look at relapse, you see that there appear to be hazard ratios favoring allogeneic stem cell transplant, with the hazard ratios 0.42 to 0.78, with the overall being 0.58, so a 42% reduction in death by having a donor. I do point you to the yellow arrow in the chemotherapy group, which involved almost 500 patients. Significant p-value was not reached because the confidence interval crossed 1. So in that particular isolated situation where the allocation was strictly to chemotherapy, allogeneic transplant did not reach statistical confidence as being superior. If you look at treatment-related mortality, there's a doubling to tripling of treatment-related mortality by having a donor, therefore undergoing allogeneic transplant. There's no surprise and no controversy. If you look at overall mortality, again, the hazard ratios are, for the most part, less than 1, but it's not true in this isolated chemotherapy allocation where there were absolutely no difference between donor and no donor. The overall, however, suggesting a 13% reduction in mortality by having a donor and presumably undergoing allogeneic transplant. The percentage of individuals allocated to transplant who underwent transplant was quite high. So I think it was on roughly almost 80%, which is actually quite remarkable. These are just the forest plots showing the same thing. The upper is the donor versus no donor where they're allocated to chemotherapy. And as you can see, the diamond is sitting there on unity, no significant p-value. If you look at autologous, then allogeneic transplant is greatly superior with a reduction of mortality with the diamond being very much to the left. In those where there was a randomization, you see the diamond is to the left and p-value is 0.05. And then when you lump everyone together, you get significance and an apparent benefit to transplant. And that generated the following curve, which is, again, true to allogeneic transplant, where transplant is doing worse for the first 2 years, and then they cross and is doing better, so that at 6 years, there's about a 7% absolute difference in outcome based on this meta-analysis. They then looked at the younger age group, under age 35, didn't present hazard ratios for treatment-related mortality, but clearly having a donor meant you were going to have a higher treatment-related mortality and didn't matter if you were young or old. But when you looked at overall mortality, the hazard ratio was 0.79 in favor of allogeneic transplant with a significant p-value, but in the older age group, it was at unity, suggesting that the real benefit of having a donor, therefore allogeneic transplant, was in this younger AYA group, if you will. At UCSF, I looked over the last decade. We had done 65 allogeneic transplants for acute lymphoblastic leukemia. We chose our patients based on high-risk features. As I outlined earlier in this talk, our overall survival is at 50% at 6 years, and our progression-free survival at 40%, so very comparable to CIBMTR data. And there was no difference, absolutely none, in outcome whether we're using a sibling donor or an unrelated donor. So are there some conclusions I can draw about allogeneic transplant? The first sentence, I think, is poor English, but it basically says, based on the meta-analysis, one would conclude that overall survival is better for those individuals with a sibling donor compared to those without a sibling donor. I would question whether we've really scientifically proven this, in particular looking at that subgroup where they were allocated only to chemotherapy. And I also point out that in these trials, these trials were designed by adult hematologists as opposed to pediatric hematologists. The comparative chemotherapy is much more adult-like than pediatric-like. So are you making the best comparison that you can? Probably not. And then I just have to say it, the data is contaminated with autologous stem cell transplant. More on that in a second. What we do know and have been reaffirmed by looking at this is that higher treatment-related mortality compared to chemotherapy if you undergo allogeneic transplant, but the trade-off is you have a lower relapse risk. And again, none of this gets into this discussion of quality of life and chronic graft versus host disease. If you have a 7% 6-year advantage, is that risk of having your quality of life disturbed really worth it? In the meta-analysis, it appeared the younger age group was doing better, but again, I'll bring you back to this. They were receiving an adult-like regimen, not a pediatric-like regimen. probably not the best comparison. And then, of course, a lot of things are going on with the cryptic translocations that our BCR-ABL like, and when we put that into chemotherapy, is all this going to become moot? Okay. Now, there's a four-letter word in ALL. It's auto. So if you say autologous, you get groans, you get sudden bilious nausea, and other types of very appropriate physiologic responses. And I'm really wondering how fair that is. I just showed you some data that doesn't look so good with that. And in fact, in the meta-analysis, they carved out those individuals who received an autograft compared to chemotherapy, and basically shows the diamond is on the right, favoring chemotherapy in terms of overall survival. And the overall survival curves look like this, where you have, at the end of the day, about a 5% absolute difference in outcome favoring chemotherapy. Well, in 1995, we put together a high-risk autologous stem cell transplant program for ALL in adults that we did a cooperative study with Stanford and City Hope. And we did this because at the time, it wasn't all that easy to get an unrelated donor. So if you didn't have a sibling donor and you had high-risk features, we still had the sense maybe an autograft would be better than just chemotherapy. I'll show you some data from UCSF tomorrow that our chemotherapy regimen resulted in 100% of these high-risk people being dead at 9 months. So we already knew our chemotherapy was going to fail these individuals. So we modeled this on success we had had in autologous stem cell transplant for acute myeloid leukemia, and that involves a very intensive myelosuppressive consolidation step using high-dose ARC and etoposide as a way to treat leukemia and mobilize peripheral blood stem cells. And then we did an in vitro purge with cocktail B antibodies or cocktail T antibodies plus complement. Those were supplied by Rob Negrin at Stanford. And then culminated with a very intensive preparative regimen for the autograft that was developed at City Hope, high-dose TBI etoposide cyclophosphamide. Probably the most intense conditioning regimen we use at UCSF. The consolidation step, 2 gram per meter squared twice a day of cytarabine for 8 doses, 40 per kilo of etoposide over 4 days. Collect the stem cells, purge, as I mentioned. The conditioning regimen, 1320 centigrade TBI, 60 per kilo of etoposide, and 100 per kilo of cyclophosphamide. And of course, when we started this, palifermin did not exist. So it was tough. We had 24 patients on study. 18 of them enrolled because they were high-risk first complete remission, 12 of them because of adverse cytogenetics that are shown here, 5 of whom were Philadelphia positive, and I have to point out this was predated tyrosine kinase inhibitors. 4 of them, it took more than 4 weeks to enter a morphologic remission, and 2 of them were high-count B-cell ALL. We also had 6 patients in second remission. Second remission adults are all going to die unless you can get them through some form of transplant. I'm not sure that principle has changed much, but maybe with some of the new products being discussed at this meeting, we can change that statement. One of those also had Philadelphia positivity. So here's our data. The event-free survival was 43% at 7 years with long follow-up. This follow-up curve was obtained in 2007, which is the last time we looked at the data. We were able to publish it, but because auto is a 4-letter word, it took us 7 attempts to get it published, and we finally had to agree to submit it as a letter. So there you go. I'll show you a curve tomorrow where this should have gone to here in 9 months. So we were very pleased with these outcomes. We did follow-up after the trial ended. We continued to do this if we couldn't find a donor and without in vitro purging. But then tyrosine kinase inhibitors came into the mix. So this is looking now at 12 patients who are Philadelphia positive. The first 5, this curve here, were on the initial trial I just showed you. 1 of the 5 were cured by this transplant without the use of a TKI. Of our others, 5 out of 7 remain in long-term remission with post-transplant imatinib. That is really good data. And in fact, that went to CLGB, became CLGB 10,001, and that has now been published. CLGB was able to confirm this. They used the UCSF method, stock, lock, and barrel, took it nationally, absolutely the same results in the Philadelphia group. So, are there any conclusions we can make about autologous stem cell transplant? Well, it's clearly not a favorable approach in the minds of most ALL leukemia physicians. But I would argue that perhaps not all autologous stem cell transplant regimens are created equal. There's variable intensity of the conditioning regimen. There's no one who's yet answered the question of purging of the autologous graft, whether that's important or not. There really hasn't been much play in ALL using post-transplant immunomodulating therapies, especially with some of the newer agents, and how might they play out. And then the other thing, if you think about it, autologous transplant is super chemotherapy, right? You don't have graft versus malignancy. If you're giving someone with ALL chemotherapy, you follow up with maintenance therapy. That is not done in autologous transplant for ALL, and I wonder if that's a mistake. Would we see much different results post-auto transplant had actually maintenance chemotherapy been put into the equation? It's not answered, and it probably never will be answered. Okay. Those are my thoughts, and happy to take, do we take questions? I don't know what we do. At the end. Okay, thank you.